You're listening to Risk and Resolve, where leadership, business, and risk management collide. We bring you real conversations, sharp insights, and strategies for success. And now for your hosts, Ben Connor and Todd Hufford.
I spent 25 years in HR and benefits at Ford Motor Company, so I'm really an HR and benefits person. And so part of my role at Ford was to convene the community, which is Kentuckiana, so the greater Louisville area, where we had about 35,000 covered lives. And so we work with hospitals, health systems, health plans, multiple healthcare stakeholders, employers to really improve community health. So that really is my background. And in that role, I had the pleasure of working with Dr. Gloria Sachdev and EFI. So I am experienced with EFI. So as you know, we have a variety of memberships. So we represent both private businesses and public purchasers, so school districts and universities, and then multiple healthcare stakeholders belong to EFI. So it's a multi-stakeholder coalition, but we are governed by employers. So a little bit about us is our mission is to improve the value received by employers and patients for their healthcare expenditures. And value includes price, quality, employee satisfaction, and utilization. So how do we do that? We do that by driving high value markets, and we'll talk about transparency. Advancing health policy, we'll talk about some of the policy wins of Indiana. Activating employers and elevating their voices, and then strengthening our movement. So EFI was formed in 2001 and by Dave Kelleher, who was the founder. And then in 2025, the EFI CEO, Gloria Sachdev, became Indiana's Secretary of Health and Family Services. So a little bit about our history. So my gosh, we've seen this slide. We've all seen this slide. So I was thinking about this. So in 2001, EFI was formed, and the Community Health Initiative in Louisville was formed. And GM, Chrysler, and Ford had these initiatives, and two of them were in Indiana, GM and Chrysler. And the cost of health care was $7,000. And I remember the autos really went all in because health care had outpaced the cost of steel. And we now buy a car for every person at $27,000 this year. And so, so I'm really bad at my job, basically. We have not done a good job of driving affordability. So when you think about that $27,000, where does the money go? 45% goes to hospital services, 32% to professional services, and I think that says 23%, to prescription drugs. But when I am talking to employers, prescription drugs really are becoming, as been focused on, a top cost driver and a real focus for employers. So let's go back to 2015. So when Gloria started at EFI, she went around to all the employers and asked, what's your top priority? And they said healthcare affordability was the top concern. And she learned in a meeting with the autos, and I won't say which one, but they said that they had a policy of ABI. They would put a factory in anywhere but Indiana because of hospital pricing. So that created the RAND Hospital Price Transparency Studies, because as you know, Gloria was a professor at Purdue and a policy researcher. So she and the employers commissioned the first hospital price transparency study. And it was really the first of its kind because we always knew we paid more, but we didn't exactly know how much we paid more, right? Like we knew this is kind of the social contract in the US. So Medicaid, Medicare, lose a little, break even, we could argue about all those things. But that commercial employer-sponsored insurance was going to pick up the rest. So this was funded by Robert Wood Johnson and Arnold Ventures. There was no funding accepted from hospitals or insurance. And so this study is hard to read, but I wanted to show it to say, this is kind of what the first study was 272% of Medicare, and that came out in 2017. That study was only done in the state of Indiana. And at the time, I was leading the Kentuckiana Health Collaborative, and I was with Ford. And so the next study was, hey, let's go national. They got 25 states involved, and it showed 311% of Medicare in the state of Indiana. Now, I want to point out that 2017 and 2019, those were facility-only prices. So when you think about the trend, you have to be mindful that different years included different states and different combination of pricing. So in 2020, we have 49 states. Indiana was 304% of Medicare, and that included facility and professional fees. RAND 4.0 was 293, and the latest is 300% of Medicare, which means that if you're an employer-sponsored insurance, you're going to pay 300% of what Medicare would pay for the same service. So, for those of us that work in this space, we were constantly downloading these files, these Excel files, and so EFI said, let's build a tool so that we can actually see this. And so it is a national tool, and it has hospital price, cost, and quality. It has ambulatory surgery center pricing, and it has physician-administered drug pricing. And then Stage 2.0 was launched to really increase the dashboard and the features. And so you can see the RAND pricing is there, the NASHB hospital cost tool, which use Medicare cost reports that I think my friends at Hancock mentioned earlier. And then CMS quality ratings, and then a couple of things, January advisors. So what's great about this is a national tool. Any legislator can pull up what hospitals are in their districts, whether they're federal or state, and then it has Quantro's Healthcare Blue Book. So where are we today? So right now, the last study that came out was 2022 data. And so Indiana is 300% of Medicare for facility plus physician. Facility fees are $338, but total physician is $127. And when you look at the national benchmark, we are 9th highest overall, 6th highest for facility fees, but 45th lowest for physician and professional fees. And so, this creates its own challenge, is this underpayment of physicians. And so I think this is a conversation that will continue to get some steam. But one of the things about the RAND studies and hospital price transparency, it really awakened many of us across the country, especially in Indiana, to say, hey, we have a problem. And Indiana has gotten a lot of national news. There's been a lot of work by policymakers to really rein in healthcare pricing, particularly hospitals, but I would also say there's been a lot of policies to control intermediaries that employers work with as well. Before we get into policy, I wanted to just talk about how you can use Sage Transparency. So we have, we just saw a perfect example of reference-based pricing between Hancock Hospital and Connor Insurance, which I think is a great example of how employers can partner with their local hospitals using Sage and RAND data. We have another employer who also has the direct contract with an employer using the RAND data. They have a great relationship. We have an employer, and actually it's public, it's 32BJ. They removed New York Presbyterian Hospital from their network. They saved $100 million and gave every employee a $3,000 bonus. And then I worked with an employer that used Sage Transparency every Friday. High cost claims come in, they would look at the pricing before they would pay, or they would work to negotiate. Now all of you are saying, hey, my health plan would never let me do that. Well, they had an independent TPA that allowed them to do that. So those are some of the case studies. And so I wanted to just transition into how transparency has led to some of our policy making. And so Indiana has really become recognized as a national leader in healthcare policy reform. And our legislators are very attuned to healthcare affordability. They have a lot of knowledge in this space. And there was a recent article that came out about Indiana's extraordinary legislative session, exemplifies how incremental effort can improve affordability. Here's a picture of Gloria on the Wall Street Journal around some of the policy reforms. But I wanted to spend just a minute about how EFI's policy engine actually works. So we have a policy committee, and we have a policy committee member here in this room that I see here today. And the policy committee works with the board and the staff and really identifies what are the things that we want to prioritize this year for policy, what are our pain points. And we also work with Hollowell Consulting, who is a policy partner of ours. And then we work with legislative champions and partners, so Hoosiers for Affordable Healthcare, Indiana Manufacturing Association. And then EFI has this brain trust that they call the brain trust. So that's Nashby, Chris Whaley from Brown University, some of the top healthcare economists. And so really all of those things combined are a pretty sophisticated policy making effort. So what I wanted to do is just at a very high level is highlight some of the policy reforms that Indiana is seeing. So what we talked about are those intermediaries. So PBMs and TPAs now have a fiduciary responsibility to plan sponsors. That is big. This is something that every state wants, and Indiana has that. It has prohibited anti-competitive contracting. So some employers are restricted from even direct contracting with their hospital. It's a contract provision. You cannot steer, you cannot tier. So this is really prohibiting those. It's also guarantees access to claims data and audit rights. So those are just a few of the intermediary market protections. Transparency for purchasers. So hospitals are required to publicly post pricing. Patients get good faith cost estimates. 340B reporting is going to the state. And then hospital pricing reform. There's a hospital price ceiling tied to the state average for the big 5 nonprofit hospitals to meet by 2029. There's a state benchmark study that just came out comparing hospital pricing to 285% of Medicare. There's a ban on off-campus facility fees. And then you see stronger market competitions, removing non-competes, hospital merger reporting, and the formulation of the APCD. So those are just some of the policy reforms that are happening in Indiana. Feel free to ask me any questions if you have any. I'll do my best. But you know, the real question is, are these policies working? I think it's a real question, right? And what that means is we have to test these laws. And so we need employers to act. If you have data access and audit rights, you should be leveraging those rights under the laws. So we're working with employers to really apply some of these laws. And House Speaker Todd Houston said that the 2027 session will be all about healthcare. So we will see what that will entail next year. So where we have kind of leaned in, and it was a question I have, remember, I'm an HR and benefit person, so my question was, okay, we have all these great laws. Are we using them? Are they working? What do I do with like fiduciary? Like, okay, how do I change my contract? What do we do? So we have hired an ERISA attorney that's really helping us translate, because we have ERISA plans, we have state plans, we have universities, we have all these different plan types. So the question is, we also have church plans. So we have this ERISA attorney who's really navigating both federal and state laws and helping employers turn these policy wins into action. So if you're asking, how do I leverage the laws? That's what we're doing. We're doing webinars on that. We have an employer portal. Behind the scenes, we have contract language you can use. We have checklists. We have charters for governance. So we're really trying to make these policy levers practical and tactical for employers to implement. And And then, so I'm not going to get too in the weeds on this, but I wanted to just highlight a really detailed example. So Indiana State Senator Chris Garden said, Hoosiers pay some of the highest healthcare costs in the nation according to several recent studies. Ensuring the health insurance industry has a fiduciary responsibility will not only lower healthcare costs for Hoosiers, but also build trust between insurance and employers they work with. So he was the author of that bill. So what we did is really take the law and then translate it into actions. And we have some resources and tools behind the scenes for employers. So, and part of what we're trying to do, for those of us that come from HR and benefits, it is actually impossible to know everything you need to know. I mean, it literally, you have people that are really good at well-being. Some people are legal contract experts. Some people are data experts. You really need all kinds of skills on benefits teams. So what we're trying to do is create, safe spaces for people to share that information. So we have a summit that we're doing. It's an employer-only summit this summer. If you're an employer and you're interested, I'd love to talk to you about joining us. But we'll really go into like, how do you optimize your benefits teams? How do you do direct contracts? We have smaller employers that are running their own health plan. I mean, it's wild, right? Like, I'm like, tell us how you're doing that. So what I wanted to do today is also just really focus on what are the top strategies for improving value? And we've already heard many of these today. And I know that Nice Healthcare is speaking after I am, but the number one thing is invest in advanced primary care. And really, we have a shortage of primary care, and I know some people have enough, head count that they can do on-site, but even a near-site clinic, some kind of partnership that both supports care management, but then optimizes health and well-being. So we heard a little bit about Hancock Hospital today. I think we'll hear from Nice Healthcare, some of the work they're doing. So that's my number one recommendation for all employers. Second, steerage to the best providers is critical. My background is quality, and the goal is to go to the highest quality care. And so you have to really think about that. So when you think about value, you're not trying to go send people to the cheapest care, you're trying to send them to the best care. And so you really have to look at quality and affordability together and always steer based on value. 3, optimize contracts. The number of contract provisions that limit employers and cost employers money is astronomical. And so really thinking about how to go in and figure out some of your PBM contracting, your TPA contracting, and really find partners that are aligned with your best interests. So we heard some of that happening today. Like, how do you find partners that are committed to your goals as an organization? And so this is a really critical step. It's something we're working on with employers at EFI. 4th, direct contract. We just heard the story today. The amount of money that we're spending in healthcare through the many layers and layers and layers and layers, hospitals and employers would be our aligned partners in communities. They're incredibly important to a thriving community. I live in Harrison County Hospital. Unfortunately, our labor and delivery unit just closed. So when you think about, and Harrison County is a big county. I grew up near Gibson County. We're seeing more desert. So we have to really think about how to contract differently. So can we direct contract as employers? I think we can. And I think we have mutually beneficial goals. And so some of the things that hospitals have to deal with that they don't like prior authorizations, can we figure out how to avoid that so that you can practice medicine? I'm not speaking for any employers because I know we care a lot about prior authorizations, but I think if you build a trusted relationship with the hospitals and you build a partnership, I think you can really have a good relationship, as we heard here today, and I know several employers have done that. Audit and review claims. This is so critical. the amount of errors and duplications and things that are happening, you really have to have a payment integrity vendor that you're working with to audit and review your claims. So I think this is really something that we're going to lean into at EFI, really helping employers navigate this. And then finally, because I am an IO person and an OD person, invest in benefits teams. No way did I know when I got into human resources that our job was to transform the American healthcare system. No, we were supposed to attract and retain talent, right? Like, wasn't that our job in HR? Is like, we're attracting and retaining talent. How do we hire people? How do we give the right benefits? And this job has gotten really, really, really hard. And so benefits teams that have the right staff and are properly and have the right skills can provide oversight. They can work on these really innovative things. Healthcare is the second largest spend of every employer. And so when we have not enough people working on it, this is part of the challenge of being a fiduciary. You have a fiduciary responsibility to provide oversight to your plan as an employer, but that's really, really hard to do because there are so many layers to healthcare. So I was part of, we wrote a paper on really, how do you do this? How do you convince your CFO, like, hey, we're going to get a return on investment if we actually invest in our benefits teams? And I will finish so that we have about 5 minutes for questions that we would love to have you join EFI. Ben said I could pitch that. And if you have any questions, I'm happy to answer any questions you have. Any question? Oh, you did have a question. Okay.
I was going to say, if you have a question, raise your hand and we'll get you a mic.
Thank you for sharing today. Who at the State House do we need to have conversation with to help advance? Are there particular senators or reps that we need to engage with as they're looking at preparing for the long session ahead?
That is a great question because for our summit, I asked the question to the policy team, what do we think is going to be on the 2027 legislative agenda? And they said it's way too early. But I think there have been hints that insurance is a target for the 2027 legislative session. So I don't know. I think really think about what's happening in the healthcare market and think about what do we need to prioritize and where is policy an important lever. And I didn't say this, but I think that policy without effective purchasing is inadequate. We as employers have to be effective at purchasing healthcare. And then secondly, policy levers can be an important support for that.
What's your greatest success? What are you most proud of right now? I mean, obviously raising awareness about the problem is great, but we've been raising awareness. Nixon said in '72, this is unsustainable, and we've sustained it pretty well since then in not a fashion that's worked for everybody. Bringing awareness, attention for your RAND studies to get them, but it seems to me that all hospital systems say, yeah, it's way too expensive. They shouldn't charge so much down the road, but if they don't shine a light on themselves. So I'm curious, what are you most proud of so far? And like you said, taking from theory to shining a light to actually action.
So I've only been in this role 7 months. So, I mean, what I'm most proud about is some of the work I did in Kentucky, which was publicly reporting, physician reporting, and quality. And I was on the Medical Society's Quality Improvement and Patient Safety. Multiple physicians came together and really aligned across all the different payers on how we can align because quality measurement and value-based care was out of control. there's no way to measure all the things that are out there. So how do we align to a parsimonious set of measures? So that's really more where I have spent a lot of my time has been on primary care. But I would say what I'm most proud of, I guess, and I think hopefully bringing into here is to really activate employers to say, we have to do a better job of being more effective purchasers. But there's a lot to learn and keep up with, and it's changing constantly. So really creating kind of a safe space to say, I don't even know what that is, because there are times where it's like, I didn't even know that was a thing. So I think really just activating employers is where I hope to lean in.
I've always appreciated what EFI has been doing in the data and research and policy arena. Obviously, you just mentioned purchasing, and I don't want to put you on the spot. If you want to punt on this question, that's totally fine. But is EFI giving any consideration to maybe moving more toward from the research and data side to an action side to helping employers? A lot of us struggle with, we're just one employer. How do we approach that hospital or whatever, with enough leverage and employer strength to enact some change? So I just wondered if EFI is considering anything like that, or if there's other thoughts on that for the future, other players. Maybe that's considered mission creep, but.
No. I mean, I think policy and research will continue to be an important part of our role because we want to make sure, and for those of you that are employers, I mean, many of you probably have a data warehouse and you're using data to leverage and figure out where you're going to focus your attention. So I think that the data and the research and making sure our policies are evidence-based is important. But what I just talked about was a lot of action series. Every month we're talking about how do you deal with compensation disclosures? How do you deal with conflicts of interest for, TPAs, PBMs, brokers and consultants? How do you lean into anti-competitive contracting? How do you do steerage? How do you do direct contracting? So those are really, I'm really leaning into how do you become a more effective purchaser? Because the policy is great, but you also have to implement the policy and leverage it. If you have access to data and you have audit rights, then you need to go, you have to be able to do those things.
Thanks for tuning in to Risk and Resolve. See you next time.